So it's almost 3:30, and for those of us on the West Coast, more like 6:30. Talking about metrics is a little complicated and keep you awake, but I'll try to do my best. I want to take you back in history because I think sometimes history is important. In 2001, I was invited to give a talk at Croy, and I put this talk called From Diagnosis to Undetectable, the Reality of HIV Care in the Inner City, and talk about what I saw as 4 different populations of patients that we were seeing. And some were HIV infected in care and long-term treatment. We like them. They're sort of patients we love. They come to clinic. They take their medicines. They're doing fine. Then there's people that are in sporadic care. They kind of come in and out of care. I call those patients the whales. You see them in the surface. They come to the surface when they develop an OI, and then they disappear into the depths of the inner city until they get sick again, and you see them again in the ER. Then there's those HIV infected but not in care either because they don't want care or they're not interested in care. And finally, there's a population of HIV uninfected who are unaware of their status. In that talk in 2001, I proposed this pyramid that was taken after Peter Piot, who had proposed this for TB testing, for latent TB infection. And I thought at that point in time, I put these numbers together and said that I thought about 10% of those living with HIV back in 2001 in the United States were actually virologically suppressed. Well, suffice to say that back then when I presented this, I was giving a lot of flack at Croy. And then when I submitted this manuscript, nobody accepted it. I got a lot of 3 different journals rejected it. And it's kind of interesting, and I say this to the young people because it took an idea 10 years to finally settle in. Because it wasn't until 2011 when this settled in, and it required several things. Number one was HRSA doing a consultation on the SPINS project, and Laura Cheever publishing this paper in 2007, talking about this spectrum of what engagement in care is. But really it was the idea that the test and treat idea that got people interested in this. And in 2010, working with Ed Gardner, we said, you know, how does this spectrum of engagement in care really have relevance to test and treat? And we went back and revised those numbers that I had done previously, and we came up with what everybody now calls a Cascade, which shortly thereafter then CDC also looked at their MMP data and did the Cascade. So again, it took 10 years, but finally now everybody's talking about the Cascade. We could have been talking 10 years ago about this, but simply people it didn't sink in. And I think it's because this engagement in care didn't have public health relevance. It was really the results of 052 and the fact that it really became very apparent that we got to get people suppressed, not only for their own good, but for population good, that I think people started saying, well, what are we doing? Because up to that point, it was all about looking, how many people are we testing, how many pills are we giving to people, but nobody was really looking at the whole spectrum. So anyway, you know, they're not that different. The numbers that Ed Gardner came up with, we're working together, we said, well, you know, maybe about 19% of people are virologically suppressed. And CDC came around and said, no, it's really more like 28% of people that are virologically suppressed. It really depends on who you look, what the numbers look like, but at the end of the day, those are not significantly. But what's interesting is for those of you that weren't in Croy this year, and by the way, the weather in Croy this year in Atlanta was so much uglier than the weather in Vancouver right now. So, you know, thank Julio for the weather right now. This is not Vancouver. March in Atlanta was not Atlanta, but that's another story. But this is the number of presentations that specifically address the Cascade at Croy. And you can see, I mean, now everybody's talking about it. So obviously, yeah, Ed is right. I mean, he deserves royalty for every time somebody talks about the Cascade. But the problem is that there are a lot of challenges in interpreting this data. And there are differences. Different measures used to calculate the Cascade step, whether it's the denominators, you know, infected, diagnosed, or living, linked to care. What do we mean by that? Is it the first visit? Is it a visit within 3 months? What is retaining care? There's a bunch of definitions about that. What is virological suppression? Are we talking about undetectable, less than 200, less than 400? And again, in general, I will tell you the calculation of Cascade steps likely produce underestimates because it depends on who's diagnosed and who's not reported. Linked or retained, but moving to other jurisdictions, and there's some data suggesting that I may have lost somebody, but in fact they went to care to somebody else. They got now a different insurance and their provider now is somewhere else. And finally, you may have people who are virologically suppressed, but not recently, but no recent viral load data is available in them, and therefore you don't count them as being suppressed. And I'll give you a couple examples of that. So if we were to take the Cascade and remove the population of HIV infected in general, then that 19 and 28 would turn to 24 and 35 because now you're using the HIV diagnosed as the denominator. And a lot of places are giving us Cascade showing us HIV diagnosed, and therefore their numbers look 30, 35%. And that's the reason, because they simply use a different denominator of who's the population they're looking at. Kaiser Permanente, Michael Horberg this year presented data at Croy in which he said to me, well, the problem is the cascade is not linear. You don't depend on what happened in the prior stage. There are plenty of people that we see that have viral loads who are undetectable, yet by your measure, they're not retaining care. There are people that are doing well, they come, they get their meds, or we know they're virologically suppressed, but not coming to clinic for whatever reason. We don't see them once a year, and therefore they're not retaining care by your definition, but they're doing fine. These are sort of a group of elite patients that are doing very well, and they're virologically suppressed. So again, the numbers may be better. Now, I must point out to Michael that his numbers are really good because I think the key to the cascade is having a healthcare system. So Kaiser and the VA in the US show really good results. France at Croy presented some really good results. And I think we have a very broken healthcare system in the United States, and our cascade is a result of that. It's just a symptom of a very broken healthcare system. But this relates to a national AIDS strategy. You can take the national AIDS strategy goals and turn them into cascade-related goals. And you can say, well, now we can look at the cascade from the national AIDS strategy. And in fact, this has been done. In a recent paper published by Gray, he said, well, let's look at surveillance systems to monitor the national AIDS strategy, and basically showed us linkage to care, virological suppression, et cetera. But again, you need to look what the definitions are. So in order to come up with definitions, and they weren't thinking cascade when they did this, but this was a very smart move. The National Office, the White House Office of the National AIDS Policy asked the Institute of Medicine to convene a committee, and in that committee, Mopley was on it, and I was on it, and Paul Volverding was the chair. And there were three goals: to recommend data and indicators to assess the impact of the National AIDS Strategy and the Patient Care Affordability Act, to assess available public and private data systems to capture HIV information, and to recommend ways to supplement and to maximize the usefulness of existing data systems. And at the end of the day, this looked into the cascade. And we came up with a series of recommendations, and this IOM report is available on the internet. And basically we said linkage is a proportion of people newly diagnosed with HIV who are linked to care within 3 months of diagnosis. Retention is a proportion of people with diagnosed HIV who are in continuous care, 2 or more visits for routine HIV care in the preceding 12 months, at least 3 months apart. And viral suppression is a proportion of people with diagnosed HIV who have been ART for 12 months and have viral loads below the level of detection. And again, you can argue with those definitions, but that's what we came up with. And if we look at this spectrum, this arrow of care, we put, and this is not for you to look at, but we basically took each one of those components and put indicators under each one, and we said, here's how all the indicators look. And if you look at the report, you'll see each one of those indicators and how you're supposed to measure them. So based on that, the Secretary of HSS sent a memo to CDC and to HRSA and said, okay guys, you need to look at the standardized core measures of HIV indicators. And the ones we're interested in is linkage to HIV care, retention and care, ARV, and viral suppression. And they were taken directly out of this IOM committee report. Now, Ryan White and HRSA did a little bit different measures, and they're trying to adjust to what the Secretary said, but they were already working on this. And they came up with a little bit different definitions, not that different, but it's a little bit different. But at Croy this year, Rupali Doshi presented some data looking at preliminary data from Ryan White clients and saying, okay, what's the outcome? And one that I want to show you is that when she looked at people retaining care by the definition, 75% of them were virologically suppressed. When she looked at people not retaining care, only 50%, again, emphasizing that people retaining care tend to do better. So it's a way to monitor how you're doing. Meg this morning talked about the WHO guidelines, the framework for metrics to support effective treatment and prevention. I don't put this for you to look at each one of those measures, but again, WHO has come up with measures because the idea is, again, how can we get the different countries to compare to each other? So the bottom line is, I think the Cascade is a powerful visual tool to monitor engagement in care at the national, state, local, or healthcare system level. It provides valuable insights into steps of HIV continuum where drop-off and engagement occurs that can help target programs to improve activities and can also be used for research. And it can be used to monitor progress in jurisdictions over time and between jurisdictions or between countries or between states if similar definitions and methodologies are used. And I think that's a big if when we're comparing cascades. I mean, be careful not to compare apples and oranges. And I want to thank by acknowledging people that helped me with this. Alan Greenberg has been working a lot on it. Jen Cates from the Kaiser Family Foundation, Rupali, Michael Horberg, and Ann Kurth, and thank our funders, the NIH through the CFAR and the NIDA, R01. Thank you.
Thank you, Carlos.